Hello,
All right.
I'm Dr. Ross Hansen, Associate Editor for Seminars in Cardiothoracic and Vascular Anesthesia. I want to welcome our viewers back. Today we're talking to Dr. Jeffrey Cardinale, who's an Assistant Professor in Anesthesiology at Ochsner Medical Center in Louisiana, New Orleans. Today he's joining us to discuss his recently published online article with us entitled Incorporation of the Transverse Thoracic Plane Block into a Multimodal Early Extubation Protocol for Cardiac Surgical Patients. Thank you for joining us today to discuss your work.
Thank you for having me.
So ERAS for cardiac surgery is an increasingly relevant topic and something that I think we're seeing a lot more of in the last couple of years, especially at this most recent SCA meeting.
Yes, sir.
How did you originally settle on the transverse thoracic plane block as the intervention that you chose to pursue for this study?
So a few years back, our CT surgeons were looking to improve their time to extubation numbers. And coincidentally, we had a visiting professor come and give us a talk. And one slide was just talking about sternotomy pain, and it mentioned several blocks. And one that caught our attention was one by Yoshima et al., a group out of Japan, that they had shown some good efficacy with these TTP blocks. And it looked fast, it looked easily reproducible. And so our goal was not to slow our surgeons down, to be able to do something quick in the operating room. And so we presented this option to them as something we thought could assist them in kind of improving times of extubation. Our first patient we tried it on, it went very smoothly. In under 5 minutes, we were done and ready for them to start prepping. At the end of the case, when we extubated him on our way up, we were asking him how he felt. He gave us the Fonzie 2 thumbs ups and said, "I feel good." And so that was kind of the start of our trial with the TTP block.
Well, that's great. I think especially your point about trying not to slow the surgeons down is really relevant, especially for folks that are out practicing in less academic centers.
Yeah.
So for those who are not as familiar with the TTP block, even though your figures in the article are very clear, do you mind just briefly discussing the anatomy and your approach to these blocks?
Sure. So once we identify the T4, T5 ribs in cross-section on ultrasound, we rotate the probe 90 degrees, kind of slide it back towards the sternum. At that point in time, you can identify the internal mammary artery, and you can see right in that area the tissue planes. And what we do is we make sure we're obviously seeing the artery, and we don't aim our needle directly towards it, but using an echogenic needle. We go for the plane between the internal intercostal and the transverse thoracic plane, transverse thoracic muscle rather. And that's where we inject our local anesthetic. It's the concentration that we're using is 0.5% bupivacaine with epinephrine added to it, unless it's a very unstable cardiac patient, as you can imagine. That might be something that could trigger arrhythmias. And so what we'll do for those patients is kind of be a little bit more cautious with our additives. But we'll inject 15 mils of that volume on either side, and that's how we do that block.
Well, and again, I would encourage any of our viewers with questions to take a look at your excellent figures that are in the paper itself in conjunction with this article. So as you discussed in the title of your article, there are other components since this was part of your multimodal early extubation protocol. Yeah. What were the other components of your multimodal approach to pain management in the study?
So we were probably a little more fentanyl heavy prior to this. And so we made it a point to include Tylenol in all of our patients that were able to tolerate it, ketamine as well. And then we started working in more Precedex. And so these were kind of the main components. Different patients dictated different needs, and so we would adjust for those accordingly. But we felt the combination of these different analgesics in conjunction with regional anesthetic really kind of presented a global approach to pain management for these patients.
So in terms of outcomes, in your paper, you distinguish between intraoperative and postoperative endpoints. Can you discuss for us a little bit each of these as they related to your findings?
Sure. Our intraoperative endpoints were, one, to increase the multimodal meds, as we just mentioned, to utilize the transverse thoracic plane block. And in doing those, kind of reduce our total fentanyl usage. We wanted to make sure that throughout this, we didn't have any major hemodynamic swings. We knew what we were getting with the fentanyl. We would get a nice stable induction. We'd get a nice stable blood pressure and heart rate on incision. And so we wanted to make sure we kind of maintained those same parameters. In addition, could we extubate these patients not just sooner, but in the OR, and could we do so comfortably with their pain control? And so those were our major intraoperative endpoints, a lot of which we achieved. We increased our extubation in the OR rate from around 8% to right at around 50%. As for the postoperative endpoints, we wanted to see if this block had any long-lasting effect on total narcotic usage, as well as pain scores. And we also wanted to look, obviously, at reintubation rates and any rates of complication. We did not notice an uptick in our reintubation rates. I think we were a little surprised to see that we didn't decrease total narcotic needs. But just like any regional block, there was a step off. As soon as the block wore off, we were kind of playing this catch-up game with the narcotics, and that's where we kind of noticed that we could have some other room for improvement.
I think one of the things that I thought was really interesting is what you just discussed about the in the OR extubations and that big chest step up from 8% to 50%. In terms of observation bias, do you guys feel like this was all primarily related to your analgesic approach? This study?
I think initially it was more related to the analgesic approach. With the first patient, we were kind of pushing to see could we do it, but when he woke up comfortably, we realized this is potentially a very strong outcome. And so it's at first the number of extubations just rose a small amount, 25%. But as we got more comfortable, we started maybe pushing a little bit more and realizing that more and more patients could tolerate this without any negative repercussions. And so ultimately, by the end of the study and currently through what we're doing now, we're still extubating at nearly a 50% rate on sometimes very complex patients. These aren't patients that are predetermined for an ERAS-specific fast track program as much as we're just giving the option to all the patients. Every one of them will give them a trial of extubation, given, again, the circumstances surrounding it. There's obviously increased bleeding risk or some other things will leave them intubated. But we'll give everybody the chance to get extubated, and if they are able to successfully do so, we'll certainly remove the breathing tube and allow them to fly.
And you touched on this a little bit earlier, but specifically, what did you guys observe in terms of reintubation rates in these patients that you're extubating in the OR?
So again, prior to the study, with our extubation rates being so low, there were not very many reintubations on that patient population. That being said, with our current trial, we had a reintubation rate of under 3%, which between ourselves and the surgeons we felt was pretty acceptable. A few of those reintubations that we've been observing are obviously secondary to increase in bleeding that was not previously observed prior to closing the chest, or something else that might necessarily be out of our realm in terms of I guess respiratory decrease in respiratory drive, for instance. And so we don't necessarily think that a couple of reintubations have been secondary to maybe decreased respiratory drive because of inadequate pain control, but a majority of it has been something that's kind of out of our hands and more on the surgical side of things. And so again, after long discussions with our surgeons, we feel that our current reintubation rate is very acceptable given the overall patient satisfaction that we're seeing with just not having a breathing tube in place.
Oh, that makes a lot of sense. Now, you touched on this a little bit before, but do you feel the TTP block in particular has any advantages over other regional techniques that you discussed or thought about using for this trial?
Yes, sir. I think that really any regional technique offers more than just a not using regional technique at all. What's nice about this technique is that as soon as a patient's asleep, we place our central line and stand at the head of the bed. You can take that probe and place it right on the chest. And from that position, if you've made everything sterile and draped appropriately, you can just stay in the same position and inject bilaterally on the either side of the sternum under 5 minutes, you've got that block accomplished, and you're not really adding any additional time to the surgical prep time. I think other blocks can take potentially longer. I know that one we're looking at now, the erector spinae plane block, we really like that. But one of the big hiccups initially was making sure that we were still fast enough to get these blocks completed before the surgeons came in there. And with the TTP block, we found especially we weren't delaying anything. And so, again, with the speed, with the reproducibility of it, we found that this was an ideal block for us. Now, there could be some concerns on the surgeon's part in terms of we are aiming a needle towards the mammary arteries. I mean, is that something that they are concerned with? Some may find some issue with that. Our surgeons have been fine, but it doesn't mean that there aren't others out there that might be concerned about that particular approach. And so, again, having a regional technique, whether it's the TTP approach or some other approach, I think in the long run, that's kind of the big picture. That's what's most beneficial for these patients and outcomes.
Sure. So taken as a whole, what do you think the most salient points from this study were that you want to impart to readers and other practitioners as they move forward and try to think about incorporating this into their practice?
I think the two big takeaways from us are, one, that early extubation within the operating room can be done safely, can be done with adequate pain control, and again, without really these negative drawbacks such as reintubations. And the second one would be, again, the use of a regional technique. In our case, we really like the TTP, but we feel that that's probably one of just several regional techniques that can be used. One thing that we know we're missing with these is obviously coverage of kind of the chest tube insertion site. So the addition of maybe a upper rectus sheath block, for instance, might be a good addition for this block. We've also been working with methadone lately, in terms of kind of managing that step off I was talking about earlier with the TTP block. When it ends, it ends, but methadone kind of smooths that out and continues to decrease their total narcotic need. So multimodal approach with a regional technique can lead to good, safe, and really the patients are very satisfied that they're not going up to the ICU, still intubated, possibly needing some pressure support because of sedation, relying on the extubation protocols in that ICU. We're controlling it, we're managing it, and really who better to manage than anesthesiologists in terms of when to extubate.
No, I couldn't agree with you more. I think this is outstanding, exciting work, and we're really interested to see where you guys take this and what else you do in the future.
I appreciate it.
Well, thank you very much for your time, and we look forward to seeing more work from you.
Yes, sir. Thank you so much.